Welcome back to our session. I hope each of you enjoyed visiting with colleagues and finding a little nourishment. As you continue eating, I'm pleased to introduce our special session 2018 Rapid Research Awardee speaker. Dr. Okoli is an associate professor at the University of Kentucky College of Nursing, and through a partnership between the UK College of Nursing, UK Healthcare, and Eastern State Hospital, serves as Director of Tobacco Treatment and Evidence-Based Practice. He started the Eastern State Hospital Research Council, thank you so much for that, and served as its first chairperson. Dr. Okoli shares his expertise today regarding the use of evidence-based practice in mental health. Please join me in giving a warm welcome to Dr. Okoli.
Thank you, Cassie. So in 1945, doctors Walter Freeman and James Watts developed a form of neurosurgery that they called, it was an intraorbital lobotomy, okay? And it involved using some pickaxe-like instruments going through some place near the eye socket and targeting specific areas in the frontal region in order to take and manage mental illnesses. Okay, so this shows us an example of using evidence in a certain way because they did some research. They found out that this procedure had been piloted by some individuals in Portugal on chimpanzees. And so they thought maybe we could extrapolate it to human beings. Now, the people in Portugal who actually piloted the procedure were able to get a Nobel Prize in regards to that procedure. Then for the next 22 years, the doctors, they performed over 5,000 lobotomies. Of those, 10% of the people died. Nearly no one was cured, and eventually, thank God, antipsychotics came in, and that practice was annulled. And so I set the stage because I'm going to talk about the use of evidence-based practice. And again, that was an example of using evidence to some degree, their clinical expertise, but they didn't really ask the patients what they preferred. Okay, so I am Okoli, and I am the Director of Tobacco Treatment Services and Evidence-Based Practices at Eastern State Hospital. So I want to talk about what the providers need to know. Our main learning objectives are to first describe what evidence-based practice is, to define it, and to describe a model, a simple model of evidence-based practice, and then give two case examples of how we can use the steps of evidence-based practice in regards to some of our mental health care. So what is evidence-based practice? So it was first defined by Sackett and colleagues as the integration of best research evidence with clinical expertise, and a key part is patient values. I like NAMI's definition, where they extend it to talk about integrating scientifically valid methods that we know are proven and replicable or have been replicated in more than one investigation. So in summary, evidence-based practice is integrating evidence that we know works, our clinical expertise, and bringing in patient values in order to care for patients. And why do we want to address this specifically mental health? Well, there have been recent studies, and these are mostly global in nature, that say that mental disorders are growing globally. As one of the presenters talked about, depression is the leading cause of disability worldwide. And from 1990 to 2010, there was a 36% increase in the disability-adjusted life years due to mental and behavioral disorders. Also, mental disorders are undertreated. So in a study that looked at past year occurrence of serious illnesses in low resource countries and high resource countries, find very high rates of people with these serious mental illnesses that are not treated. But evidence-based practices exist, and SAMHSA has done a really good job to create a repository. If you've never gone, I highly encourage you to go to this website, click on it, and you can see many bona fide approaches in our treatment for mental and behavioral disorders. But unfortunately, evidence-based practice engagement may be declining. So a national survey, the National Medical Expenditure Panel Survey, found a decrease in the average uptake or use of some evidence-based practices, primarily in the outpatient setting. But the goals of evidence-based practice are really to provide evidence. You know, in my work, I wear two hats, clinician, researcher, and the hats work together very well. As a researcher, we want to provide evidence. But as a clinician, I want to provide evidence that makes sense and is meaningful. And so many times, as clinicians working at the bedsides, working with patients, we have the right questions that will have the impact. But we need the designs and the evidence to put those things together to make some profound impacts. So key is to provide some form of evidence-based data. And of course, it resolves some of our clinical problems, the challenges we constantly face and see in our clinical practice. It brings in innovative solutions, just like Eastern States' direct values. You know, innovation is one of them. So evidence-based practice can bring very innovative solutions. It can reduce variations in care. We might be doing the same thing where somebody has already done it, but we're just repeating some failed experiences. It will promote efficient and effective decisions in our care, especially in situations where we have resources that are limited. And ultimately, it will achieve excellent care delivery and outcomes. So sometimes it's worth taking a look at the distinctions between evidence-based practice, research, and quality improvement. And in terms of the methodologies, there are some distinctions that have been proposed in the literature. The key with evidence-based practice is we really want to know what is the level of evidence in order to make a decision about a change in practice. With research, we use different methodologies to inform our research inquiry. And with quality improvement, we also use certain methodologies. And with evidence-based practice, the focus is the population, our patient population. Sometimes you need IRB approval to do it, sometimes you don't. And with data collection, we're really looking at existing research. We appraise it as well. We want to see what the impact of this research evidence is, and we want to eventually have a practice change. This can be a change in our policies and procedures. And we disseminate it primarily through changes in practice standards. When we think about the model, the simplistic model of evidence-based practice, you can tell I've repeated this several times so that we will get it by the end. We take the best evidence that we know, we think about our professional practice, and we include our client or patient values and preferences. Often what tends to be missing is the inclusion of our patient values and preferences, especially in mental health care. As the example I illustrated in the beginning, with lobotomies, I don't think they were asking the patients if they wanted those procedures done in them. A more transdisciplinary model of evidence-based practice includes an understanding of the environment in which care is provided, as well as the resources that are available to implement any change in practice. So I'm going to go through a few slides detailing the steps or the how-to with evidence-based practice. And there are 5 main steps, which involve asking the right questions, finding and appraising the best evidence, integrating this evidence into your practice, implementing a practice change, and then evaluating these outcomes. So when we ask a question, we need to ask an answerable question. And that means when we're defining the question of our inquiry, we have an observation at the bedside. We observe that between 2 p.m. and 5 p.m., there's an increase in altercations or something at the hospital. So we come up with a novel solution of providing snacks. Well, the solution comes from having the right question. So we ask which of our practices are evidence-based and which are not. What am I doing? And why am I doing it to my patients? And which patient outcomes should or could be better, and why are they not? And the way that helps me define or get the right question is to use a PICO format. And that means that we write a question keeping in mind the patient population, our intervention of interest, a comparison group if necessary, the outcome, and timing. So as an example of a PICO format, I'll give 2 examples, one with a comparison group, one without. So the first one is, in patients with substance use disorders, what is the effect of a drug and alcohol education program, nod to Cassie, on motivation to engage in substance use treatment at the end of 3 sessions? So I guess I go back. Well, I had all these fancy things that would tell you what the very specific pieces are, but our patient population here is patients with substance use disorders. The drug and alcohol education is our intervention, and motivation to engage is our outcome. So with another example, in patients with schizophrenia, what is the comparative effectiveness of oral compared to long-acting injectables on attendance scheduled mental health appointments after discharge? Okay, so I think on this slide, I kind of break it down. Yeah, so that's the population. That's an example of the intervention, the timing, and the outcome. Again, when we use a PICO format, it really helps us know what we're asking and how to measure our outcome. Okay, so that's just another example of the population, intervention and comparison group, the oral versus long-acting injectables, and then our outcome and our time. Okay, so the second aspect of the step in the evidence-based practice is to find and appraise the best available evidence. But the best available evidence really depends on the type of question we ask. And so when we're looking at the best available evidence, we want the evidence that eliminates the most bias as much as possible. There are no perfect studies, but some are more trustworthy than others. So we have to have in mind an idea of levels of evidence. And in terms of considering what evidence out there is best, the top levels are typically our systematic reviews, our meta-analyses, followed by single randomized control designs, then systematic reviews of correlational observational studies, single correlational observational studies, and so on. But the least level of evidence is opinions of authorities, experts, committees. Now, we're not saying that they aren't levels of evidence, because sometimes you may begin a project or a line of inquiry where there really is no evidence. And what you come up with are case studies. And these might be the opinions of authorities and expert committees. So you've got to start somewhere. Another way of looking at it is the evidence pyramid. And like I mentioned, the Cochrane system of reviews is one of the top levels of evidence, just because they've done very rigorous methods of eliminating biases or acknowledging biases in studies that exist, and then so on, meta-analyses, systematic reviews, and so on. So I'm just going to go through some slides about what these websites or data repositories look like. So you can get evidence from data repositories. In nursing and allied health, we typically use CINAHL. In medicine, we typically use the PubMed. And psychology, social work, I know you do use EBSCOhost and PsycInfo. Forgot to put PsycInfo. But also journal articles in your respective professional journals are good sources of evidence. And then there are many professional organizations that will have position statements. So they've done some sort of review about a topic, and those are good sources of evidence as well. Just again, some illustrations of evidence. So this is what the Cochrane website looks like. You can type in the search site and ask different questions, and you'll get a lot of different meta-analyses, systematic reviews that have been done quite well. Another source is the Agency for Healthcare Research and Quality. Provides a lot of evidence on both population and also guidelines in their clearinghouse. PubMed is one where you can put in mesh terms or keyword searches and look for very specific articles. Again, EBSCOhost is another data repository similar to PubMed where you can do some searches. One I like to point out, we have some pharmacy folk here, so we have the Micromedics, which is a good repository for if you're looking at drug use, drug interactions, and how they can be effective if you have an area of inquiry that involves medications. Well, a question that often comes up is, what if there is no evidence? Then you conduct a research study. And it's really good to have first, as we do in our research council, a multidisciplinary group of individuals who can come together and think about an issue and observation from different viewpoints. And then we can consider what would be the best way to do the research study. There are several designs. You could do some sort of retrospective design, prospective studies, randomized controlled studies, just depending on what would be the best way to answer your question of inquiry. And then you can always apply for a research grant. Again, I give a shout out to the Research Council. That's what we are here for. If you need to figure out a way to maybe apply for a grant, look at data, even write a proposal, we're here to help out. So when we do a search in the data repositories or in the journals of your profession, we have to appraise the evidence. And there are several evidence appraisal tools. But the key things we want to know is, does the study have very well-defined purpose, aims, hypotheses, objectives? Is the research design rigorous enough to answer the questions they wanted to? Is the population of interest the one that would best match our population of interest? And were the data analyzed appropriately? Were issues of the reliability and the validity of the study addressed? Could they be related to other studies, especially when we want to make sure things are replicable? Were they conducted ethically? Again, I won't talk about, the initial lobotomy studies. And do they have any relevance in terms of their implication for practice? So when we consider integrating the evidence with clinical expertise and patient preferences, again, we do want to have a sense of interdisciplinary, multidisciplinary, and even transdisciplinary. So interdisciplinary is when different disciplines work together. So maybe two disciplines, social work, nursing, medicine, nursing, work together to address an issue. Multidisciplinary is when we have probably more than two disciplines. What I like about transdisciplinary is, one idea of transdisciplinary research is we bring in our different disciplinary perspectives, but we create something that's more than our disciplinary perspectives. So sometimes I may come in from a nursing perspective and I'm looking at patient outcomes in a very specific way. Psychology comes in looking at measurement issues in the patient outcome. And then we come up with an even better way to measure the patient outcomes that's beyond nursing or psychology. And that's the goal of transdisciplinary research. We have to consider the context in which the research, the evidence-based practice is being conducted. We always want to align to the mission of the organization. That's the way you get buy-in, as well as our culture. We have to consider, is it something feasible in an inpatient or outpatient setting? And key are the patient preferences and values. I'm learning in my research program that initially I was very driven by what the evidence says. But much lately, I'm bringing in the consumers into the research, and it makes it so much more, it makes it richer, but it makes it more meaningful, and it ensures it can be disseminated appropriately. And of course, we have to think about the resource availability within the context of where we want to do this study. Do we have the human capital? A very practical example is when we work with IRBs, one question they ask is, if you're going to do this program, how is it going to affect the workflow of the staff? You know, is it something that I'm going to say, oh yeah, I would love the suicide, Columbia suicide assessments done everywhere, universal. Well, how is that going to affect the workflow? And does it make sense to have everybody doing it? Well, the evidence suggests yes, versus a team of people doing it, all depending on your context. Okay. When we think about implementing the practice change, the key thing is to engage stakeholders. So this would involve the patients, the workers, your coworkers, colleagues, and management, in order to ensure that whatever you've observed and you want to make a change meets the values of everybody. We need to secure administrative support in order to write a grant if we need to, or figure out where to get the funds to do it. We should disseminate the evidence, and that could be done through developing policies, procedures, and guidelines, publishing our work. And we need to consider if we need to obtain additional resources to do our work. And it's always good to pilot test. So I'm going to give a little shout out to Norton Healthcare, just because I know a little bit of what they do. They have these things they call alpha units. So anytime they want to bring an innovation throughout their system, they test it, and I think on 5 units. They do a pilot test. If it works, and these units are live units, okay? They're not just mock units. They're just 5 units that they select to test things. If it works, it goes enterprise-wide. If it doesn't, the pilot test didn't work, okay? So I think that's a really innovative way of doing pilot testing in systems. Then finally, we want to evaluate our outcomes, and evaluation includes different aspects. Are they clinical outcomes? So these may involve things like clinical measures, blood pressure measures, HbA1c for having blood sugar tests, reduced weights. We want to include quality of life measures. Do we want to improve the socialization of our patients, their emotional health, spiritual health? Economic measures. Will it increase cost savings, maybe to our patients, maybe to our organization? How do we improve things that are relevant to the healthcare system? How do we get those Press-Ganey satisfaction scores up? And in the healthcare system as well, can we improve the efficiency of how we deliver our care? Can we reduce readmission, things like that? And the best way to find out what these measures are is to go to the literature and see what has been measured and how it's been defined. Again, I appreciate Adam Lester's presentation of how when they were considering suicide, the language that's used is not universal across different studies, so they came out with universal definitions. Okay, So I'm going to give two case examples of how we've used evidence-based practice principles in addressing some issues of importance. One is the issue of nicotine withdrawal management. Those who know me, I can't give a presentation without talking about tobacco use. Okay, so I'll be in keeping with that aspect of my work. But the second is something newer, where we will address secondary traumatic stress or vicarious stress among healthcare workers. So with nicotine withdrawal management, Eastern State Hospital is tobacco-free. No one is supposed to use any tobacco products among the premise. But that means that when tobacco users, and we have on average about 62% of our patient population that's admitted use tobacco, when they come into the hospital, they are put into a state of forced abstinence. It's not voluntary most of the time. For some it is. They're kind of happy that they don't have to use tobacco. But for the majority, it's forced abstinence. And when a person is put in that state, the biggest challenge is they will go through some form of nicotine withdrawal. And how do we manage their nicotine withdrawal? It's important to recognize that nicotine replacement therapy and some oral medications like varenicline and bupropion are FDA approved to address nicotine withdrawal when individuals are engaged in tobacco cessation. Okay? When they're engaged, they want to quit smoking, they want to stop. The FDA has approved these medications for it. But we don't have any guidelines for when somebody's put into forced abstinence. They don't really want to engage in tobacco treatment. And questions arise, well, the dosages that are recommended for smoking cessation, are they the same as the dosages that would be recommended for nicotine withdrawal? We don't know. So we wanted to understand how best can we manage nicotine withdrawal among inpatients who also have comorbid psychiatric problems. So we asked an answerable question. Among tobacco-using patients, what is the effect of providing nicotine replacement at admission on nicotine withdrawal symptoms? Okay, so Eastern State Hospital has a protocol. When any patient is admitted, their tobacco use is assessed, and the admitting physician or healthcare provider will offer them nicotine replacement therapy. So we have that protocol in place. What we didn't have in place is to monitor the consequences of doing that. So we went to the literature to get the best evidence. And we found 4 main studies. Among the psychiatric population, 2 were based in outpatient, and they were based on surveys, and 2 were based in inpatient, more relevant to us. So we wanted to ask 2 questions. One, how do others manage nicotine withdrawal? And the second is, how do they measure it? So based on our appraisal of the evidence, we came up with the Minnesota Nicotine Withdrawal Scale, which is a 7-item, easy-to-use scale that could be implemented in practice. And we did observe that others have looked at how NRT affects, nicotine replacement therapy affects nicotine withdrawal, but it's not very conclusive. So in integrating the evidence, we used the Minnesota Nicotine Withdrawal Scale. And as I mentioned, we have the process where we offer the nicotine patch to our patients. And I spoke to some of the primary care providers and said, well, why don't we offer gum or lozenge? These are other nicotine replacement forms. And there were issues of our culture because patients would use gum and stick it on the units. So that was not a value that we wanted to endorse. The other aspect was that nicotine lozenges were just a little too expensive for our pharmacy budget. Again, so these are questions of resource and our preferences and culture. So what was most acceptable was the nicotine patch. So we provided clinicians on the use of nicotine replacement in terms of tobacco products. So, and I want to put a plug in for the next segment when we're going to talk a little bit about what it took to create a pamphlet to talk about nicotine equivalents. So we have a relatively good idea that for every cigarette, you absorb about 1 milligram of nicotine. A pack of cigarettes has about 20 milligrams. So if somebody is smoking a pack a day, they need at least a 21 milligram patch replacement, right? So very logical, very clear. But what if they're smoking pipes or roll their owns or e-cigarettes? Okay. We don't have much evidence of what those nicotine equivalencies would be for those products. So we had to do extra research for that, and later on Yazan's going to present that. And we also needed to figure out what would be the best form of assessing nicotine withdrawal that wasn't very burdensome. And again, the Minnesota Nicotine Withdrawal Scale would be used for that. Now, the authors of the scale may not necessarily endorse it for clinical practice, but it is the shortest. There are other versions out there. Some are 21 questions, some are 30 questions. And you can imagine trying to ask 21 questions on a patient, inpatient. It's not going to work. So this was the shortest version that has very good reliability and validity, but it's been mostly used for research. So the question is, can you adapt it to clinical practice? So we implemented a change. We began monitoring nicotine withdrawal on the patient, on the units, January 2016. The flow was that patients were offered NRT at admission. The tobacco treatment nurse, thank you for the resources of our administration. They gave us a tobacco treatment nurse, which is awesome. And she would monitor nicotine withdrawal, and based on the scoring, she would go back to the admitting physician and inform them that our patient is still scoring high so they could give them more nicotine replacement therapy. All right, trying to move forward. So of 356 individuals admitted in that year, we had about 2,751 admissions that year. Of them, about 1,750 were tobacco users. Of those tobacco users, 356 were willing to have the nicotine withdrawal scale applied to them. And we didn't really need IRB for this study. We got an exemption certificate because it's based on existing data. We were doing a retrospective review. So what we found, about 68%, the highest rated nicotine withdrawal symptom was craving, followed by others. And as you can see, restlessness, concentration, anxiety, insomnia, depression, they kind of sound like other symptoms that our patients face, right? So that was another question. Is the nicotine withdrawal syndrome specific enough to capture nicotine withdrawal apart from the symptoms of psychiatric illness? Okay. These bring up other research questions. But the good news was when we began monitoring nicotine withdrawal, and because of the tobacco treatment nurse being able to go back and tell the attending that the patients may need more patch, we saw a decrease over the year in nicotine withdrawal symptom scale. So that told us that at least implementing the tobacco treatment nurse and this process resulted in our patients not withdrawing as much. And we got our study published. And I only put this out there, one, to show, Dr. Shelton, we have to give a shout out to him. But this is one way that we disseminate our evidence-based practice. And I'm a big proponent of not being intimidated about publishing, because it's part of what we do as clinical researchers and as clinicians. It's another way that we now have informed the extant evidence about using nicotine replacement therapy and its effectiveness within inpatient psychiatric settings. So some future questions we had. Now we know nicotine replacement therapy can help with nicotine withdrawal, but is nicotine replacement therapy the best method to help with nicotine withdrawal? We have other options. We've got varenicline. And the nice thing about varenicline as a medication is that it actually mostly addresses cravings. So it acts in a unique way in the brain that has been shown to actually reduce cravings. So maybe during an inpatient tobacco-free stay, varenicline may address those cravings, which nicotine patch and others may not. So that calls for future studies. The second case I'd like to present is something newer. It's still ongoing, so I'm just going to present some of our preliminary findings. But we observed, we went to a conference about 3 years ago, and there's an expert in vicarious stress or vicarious secondary trauma. Her name is Cheryl Beck, and she talked about cases of how healthcare workers in the line of work constantly experience symptoms due to their observing violent incidences or traumatic experiences with patients, things like PTSD, post-traumatic stress disorder. So that is classified as secondary traumatic stress. What we don't know is within the UK enterprise, what are the levels and for whom is secondary traumatic stress most impacted among both disciplines, but also work settings. So we asked the question, among UK healthcare staff and providers, this includes Chandler, Good Sam, and Eastern State Hospital, and outpatient services, how does secondary traumatic stress differ by disciplinary background and by work setting? So how do you measure it? We went to the literature, and there are two main measures of secondary traumatic stress. One of them is by Figley and colleagues. It's called the Secondary Traumatic Stress Scale. It's 17 items. It has good validity and reliability. There's a shorter scale, which is within the Professional Quality of Life Secondary Traumatic Stress subscale. It has 10 items and equally good validity and reliability. The advantage of the Professional Quality of Life scale, it also measures burnout and compassion satisfaction for a total of 30 questions. I'm not presenting on the burnout. I know everyone wants to hear that. I won't present on the burnout or compassion satisfaction in this presentation, but we're still analyzing the data. But we went with the 10-item subscale of the second traumatic stress. So in this case, our patients are our colleagues, so they're the staff. And we formed an interdisciplinary team of clinicians and researchers across UK, Chandler, Good Samaritan, Eastern State Hospital. And we came up with a consensus that the Professional Quality of Life survey, the secondary traumatic stress subscale, would be the best one that we could use. So we began to conduct our surveys in November 2018 till April 2019, and some of you probably responded, so thank you, thank you, thank you. We can't do this work without your help. We had aimed for about 900 surveys. We got 1,006. 900 was because we have about 9,000 workers within the UK healthcare enterprise. So we were aiming for at least 10%. We got 1,006. Of those 1,006, 764 responded to the secondary traumatic stress subscale questions. So our population, our survey sample is based on these individuals. On average, those who responded to the survey were mostly nursing staff. And we were I don't know why, but we forgot to actually list pharmacy as one of the options to check. And we had an other category. So many pharmacists responded, thank you, thank you, thank you, and apologies from us, because they said, you do know we are a discipline. Is this survey really for us? You omitted us. So we learn from these sort of processes. And the main setting from where most people came from were the general medical wards at Good Sam and also at Chandler Hospital. So when we look at secondary traumatic stress scale scores, those with the highest scores, and these are statistically significantly different. We had to combine social work and psychology into one group just because the sample of psychologists were so few. So I did talk to some of my colleagues, and they thought it's a reasonable combination. But they had the highest secondary traumatic stress scores. And all the other disciplines were quite similar. Okay. When we looked at the work setting with the highest scores, as you would imagine, it was mostly those in the emergency departments, followed by those in the intensive care units. I thought psychiatric services would really be up there, but we did include in our survey behavioral health outpatients. We combined them, so they may have changed the means of the scale scores. So these evidence-based models can help us answer these sort of questions that are important, that are based on observations that we see. And in the future, what we learned from this study is that we do have specific disciplines that are higher risk for secondary traumatic stress, and we have specific settings that are a higher risk. And so it would be prudent for us to go back to the literature, get the best evidence that discusses how to mitigate secondary traumatic stress so that we can perhaps develop tailored or targeted interventions with these specific disciplines and settings in mind. And as an overall summary to this talk, there is a need for evidence-based practice in mental health care. In order for us to best improve our care for our patients, we need to take systematic approaches. And I hope through this presentation, I expect that I was able to show the steps that we can use to take very systematic approaches to answer our questions of inquiry. And these projects, the ones I presented, demonstrate that we can be effective in our patient care practices and can lead to the next steps of how we develop targeted or tailored interventions to address some of the issues that we face. I'd be happy to entertain any questions. Cassie.
I would love it if you would explain the difference between a targeted and a tailored intervention, and how any particular study can identify which or both may be appropriate.
Okay. So one way to think about targeted interventions are we recognize maybe a community of people who are at higher risk, aka social workers and psychologists, okay? And so we would get interventions that we know work in reducing secondary traumatic stress and apply it, target those social workers, psychologists, maybe nurses, maybe advanced care providers. You target it to populations. A tailored approach would be taking those interventions and knowing what social workers and psychologists value, tweaking the interventions so that it's acceptable to them. So one example, I did some of my earlier work in Canada, and we were trying to inform young people, adolescents, it's always fun to do research with them, about These are First Nations, so Native Americans, well, First Nations in Canada. We wanted to inform them about the risks of secondhand smoke exposure and breast cancer. And we asked them, so how would we create information packets that are tailored to the First Nation people? And we were told, well, you have to have dream catchers and feathers. Because if you create a pamphlet without dream catchers and feathers, it's not relevant to them. It could be for any youth. But once you put feathers and dream catchers, they know it's for First Nation youth. And then some said, and the color of the feathers matter. Because if I'm a Haida youth or a Hopi or a Mohican, the colors matter for my nation. So that's an example of tailoring messages to specific populations. Okay. Any other questions? So I can go have my lunch. Thank you.